This module covers the anticoagulant medications that can be seen in interfacility transport in Colorado. My name is Kelly Weber and I am a paramedic with Stadium Medical. Interfacility transport is a rapidly growing part of today's medicine that expands the continuum of patient care. Fortunately, the increased need for this type of transport has greatly integrated the EMS provider. Unfortunately, many of the interventions and medications these patients receive in hospital are not part of national EMS education standards. The Colorado Department of Public Health and Environment Code of Colorado Regulations for EMS Professionals outlines such medications along with special waivers for EMS systems that lie outside the governing protocols of EMS personnel and are reserved for interfacility transport only. 3 drug classes written in these regulations are listed here. Note that each of them are to be monitored by a paramedic only. I would argue that glycoprotein inhibitors are mislabeled, but we will get to that later. This module will address the anticoagulant, antiplatelet subcategory of the cardiovascular portion of this formulary, in efforts to familiarize the IFT paramedic on the basic pharmacology, indications for use, and side effects of such medicines. Note that these medicines must have been initiated in hospital only and are not allowed to be initiated in the field. The paramedic should continue the same standard of care that was begun in the facility, and additions to treatment regimens requires a direct verbal order from the medical director. Remember that you, as the medical provider, reserve the right to decline transport of a patient if you feel that their care requires a level beyond your capability or comfort. Different antithrombotic agents are called for in the treatment or management of certain ailments with varying pathophysiologies. Keep in mind these definitions. Venous thrombi are composed mainly of fibrin and trapped red blood cells with relatively few platelets within them. Arterial thrombi are composed mainly of platelets that are held together by small amounts of fibrin. Anticoagulant agents are the drug of choice for prevention and treatment of venous thromboembolisms and for the prevention of cardioembolic events in patients with atrial fibrillation. Anticoagulants are also effective for arterial thrombosis, and their effects can be additive with platelet agents. Antiplatelet agents are the drug of choice primarily for the prevention and treatment of arterial thrombi. These can be primary and secondary prevention mechanisms and treatment mechanisms of acute coronary syndrome. Some physiology review will help guide our discussion of this medication class. The coagulation cascade is a series of reactions in which a clotting factor becomes activated by proteolysis, thus becoming an active enzyme that turns to the next factor to activate it, and so on. Calcium and certain surface proteins of platelets are also involved. 2 different pathways ultimately merge towards the end result of a clot formation. They begin both with tissue damage. This tissue damage can occur intrinsically, meaning within the blood vessel itself, or extrinsically, meaning outside the blood vessel. Imagine the difference between a paper cut causing a clot, extrinsic, and chronically high blood pressure causing endothelial damage, intrinsic. No matter the source of tissue damage, ultimately factor 10 is activated, which begins the common pathway. Here you have the conversion of prothrombin to thrombin and fibrinogen conversion to fibrin. Fibrin acts as a web of sorts to net the platelets together and in the final formation of a clot. Here you see the details of both pathways. It is important to appreciate the intricacies of these cascade so that you can conceptualize where we can target this system with drug therapy. Each step allows a unique vantage point for the treatment of certain disorders where clots cause serious problems. The heparin family of drugs acts within the plasma to inhibit certain clotting factors. Indirectly, these drugs bind to and accelerate the activity of antithrombin 3. This antithrombin 3 heparin complex inhibits factors 2A, 9A, 10A, 11A, 12A, and 13A, which ultimately prevents the conversion of prothrombin to thrombin and fibrinogen to fibrin. This will equal no clot formation. Continuous infusion of certain heparins, either intravenously or subcutaneously, is preferred for the constant therapeutic effect and decreased bleeding complications, as intermittent therapy will require boluses of much higher doses. Generally, the heparin family is used to prevent states of hypercoagulability that follows vascular injury or venous stasis. It is seen as an adjunct treatment of coronary occlusion and unstable angina and/or acute MI. They serve as both prophylaxis and therapy of venous thromboemboli, whether that be a deep vein thrombosis or a pulmonary embolism, as well as the prevention of cerebral thrombosis in suspected evolving stroke, and in low doses, the prophylaxis of postoperative thromboembolism. This family of anticoagulants does not clot the placenta and is therefore considered safe in all pregnant patients. Low molecular weight heparins are subclasses of the heparin family. They share the mechanism of binding to plasma factor antithrombin 3, but then work to inhibit factor 10A. The product within the low molecular weight heparin umbrella then have varying degrees of affinity for the other clotting factors. Therefore, they are not necessarily interchangeable and allow the healthcare provider more targeted therapy based on the problem and more predictable anticoagulant properties. These properties generally make low molecular weight heparin preferred over unfractionated heparin. However, heparin is more easily reversed in an overdose situation and may be safer with patients with renal impairment. When caring for a patient who is being actively infused with a heparin product, be advised that hemorrhage can and does occur in approximately 10% of patients. Due mainly to their endocrine physiology, elderly women are most prone to this side effect. Be wary of the patient that experiences nosebleeds en route, as this may be a sign of overdose. Other warning signs of overdose are if your patient tells you they have noticed blood in their urine or black tarry stools. Bruising may be an early warning sign of impending hemorrhage. So if any of these signs or symptoms are noted in your head-to-toe exam en route, note them and report them to the receiving facility. If you note the patient has been taking heparin products chronically or greater than 6-month period of time, know that osteoporosis can occur in this population and should be noted in instances of trauma. As with any drug, hypersensitivity may also occur and will present with hives, fever, and/or chills as common chief complaints. A sometimes serious blood disorder called thrombocytopenia or low platelet levels can also occur within 5 to 10 days of the initiation of heparin therapy. This will present as increased ease of bleeding, bruising, or a pinpoint rash called petechiae. You will usually see these in the lower limbs first. Remember, history is always key. This picture represents the interaction between platelets and the lining of blood vessels when injury calls for a blood clot to form. Certain glycoproteins, depicted here in yellow, lie within the cell membrane of platelets. In normal circumstances, the endothelium of vessels are undamaged, and the underlying collagen and tissue factors are hidden from the circulating platelets. If damage occurs and this collagen is exposed, glycoproteins bind to these factors and activate the platelet in beginning stages of the coagulation cascade. Activated platelets release contents from granules within their cytoplasm. These will serve as messages to other platelets and become active. Some of these messages activate other membrane-bound glycoproteins that have high affinity for fibrinogen, the pre-fibrin factor we spoke of earlier. Once fibrinogen is bound to these glycoproteins, they change shape and cross-link neighboring platelets to form a larger and larger clot as fibrinogen is activated into fibrin. If this avenue of clot formation occurs inappropriately, the healthcare provider can target this fibrinogen glycoprotein interaction with a class of drugs called glycoprotein inhibitors. You will most commonly see glycoprotein inhibitors used as an adjunct treatment for patients who have undergone or are going to receive angioplasty in the cath lab, with and without stent placement. They may also be used in the treatment or prevention of unstable angina or other coronary syndromes concerning for thrombus formation. Note that they can be given in conjunction with heparin products and are intravenous only. The most common adverse reaction to glycoprotein inhibitors is increased bleeding, which will present very similarly to the overdoses of heparin products that we discussed earlier. The difference here is that there is no reversal agent to this drug class, and in severe cases, platelet transfusion may be necessary. Be aware that if you are caring for a patient on both a glycoprotein inhibitor and a heparin product, their increased bleeding risk is great. This has been a brief overview of common antithrombotic agents you may encounter